A do not resuscitate or DNR order is a legal and medical order that documents a patient's wish to avoid any form of resuscitation intervention in the event that he or she was to experience a cardiac and/or respiratory arrest. These orders can be revoked by a patient at any time. Such interventions may include cardiopulmonary resuscitation, chest compressions, defibrillation, or advanced cardiovascular life support. These measures aim to pump blood to the brain in order to prevent brain death and to restart regular cardiac and respiratory cycles whilst other help arrives. DNRs are associated with, but certainly not limited to, the elderly. Surveys outlined by Cherniak in 2002 show that the use of DNR orders has been increasing not only in the elderly, but in all individuals over the past several decades. However, elderly patients are more likely to have a DNR in place surrounding their death. So why is this? The elderly may put a DNR in place for a number of reasons. These include the acceptance of an approaching death, fear of poor quality of life after resuscitation, or the relief from the prolonged pain and suffering associated with extensive deterioration of health due to terminal illnesses such as cancer. Diverse and extensive groups of information were gathered from literature studying DNR within the elderly. The primary focus of these groups of articles often surrounded the effect of age and health on the outcome of resuscitation and the competency of the elderly to understand their situation and the outcomes and risks associated with the DNR order. Many of these literature forms noted the lack of clarity surrounding laws and responsibilities of physicians around DNRs in the hospital setting and advocated for further education to enable a mutual understanding. The decision by a medical practitioner to resuscitate or not to resuscitate is often a gray area. This ambiguity may be attributed to outcome specificity and individualization of circumstances. This in turn holds the potential for ongoing conflict. Within the arguments that favor the use of DNR orders, reduced quality of life after a patient has been resuscitated is frequently contended. When a patient suffers cardiac or respiratory arrest, blood flow to the brain stops. If this is prolonged, then hypoxic brain damage may occur. The Brain and Spinal Cord Organization in paragraph 9 states that in extreme circumstances, this can leave patients with paralysis in vegetative states with speech and language deficiencies alongside problems interpreting emotion. The significant reduction in quality of life is commonplace, with only 3 to 7% able to return their previous level of function. Specifically in the elderly community, age-related frailties and illnesses reduce the success of CPR and increase the likelihood of poor outcomes occurring. Another argument in favor of the use of DNR orders focuses on the costs and resources associated with resuscitations. Arnold in 1988 contended that there is a clear need for us to ensure the futile attempts at resuscitation are minimized. Futility refers to the expenditure of time and money on performing seemingly pointless medical treatment such as resuscitation, where there are high risks of or expected negative outcomes. This argument focuses on the bioethical principle of justice, where it proposes that the money and resources in healthcare should be invested and provided to those who will most likely benefit from it. Despite the low in-hospital resuscitation survival rate to discharge of 18%, CPR is still a common procedure. Timmermans and Sheen in 2010 concluded that the average cost of unsuccessful CPR attempts in emergency department was $4,150 per patient. This argument in cost and futility is controversial, with Kirrily in 2009, contending that we should reject the concept of futility and recognize the right of an individual to be involved in decisions about CPR, even when there is very little chance of it succeeding. The range of issues surrounding DNR orders outline the complexity of its very nature. Ethical and clinical and professional issues arise in patient and physicians dealing with patients wanting a DNR order. May be regarded as murder at the hands of a physician following a DNR order and ending the life of another person. This goes against the bioethical principle of non-maleficence, that is, to do no harm to the patient. Denying a patient autonomy, informing them of the risk and nature of DNR orders so they can make well-informed decisions. The aspect of futility and justice, as mentioned previously, involves using up resources and money on the elderly with low rates of survival. Physicians' own preferences for or beliefs on CPR may impact on the DNR decision making process for their patient. Cherniak in 2002 found that physicians may not even want the participation of elderly or believe that it is necessary in decisions regarding CPR during emergency cardiac arrest. Cherniak also found that elderly patients are often uninformed by practitioners about the details of the procedure or overestimate the chances of success. Physicians may fail to ask the elderly of their preferences before it is too late, resulting in resuscitation performed in contrast to the wishes of the patient. Personal or professional beliefs may hold the potential for the health professional discounting the wishes or belief of the patient, placing their beliefs above that of the patient's. However, they must also perform their care duty within a particular scope of practice. Contrasting ideas and beliefs may cause conflict between physician and family or physician and patient. Emergency workers, as revealed by SBS Insights episode 39 on Do Not Resuscitate, are often greatly impacted by dealings with cases involving resuscitation interventions. These experiences may have detrimental and lasting impacts on the mental health of professionals, hindering their ability to perform the appropriate duty of care and affecting the ways in which they think, live, and deliver emergency care. Appropriate and effective communication between a practitioner and the patient when making decisions regarding resuscitation remains a very important aspect of a DNR order and its implementation. Cherniak in 2002 suggests that as many physicians often disregard DNR orders, wide discussion forums including physicians, ethicists, lawyers, and hospital administrators might help allow considerations of physicians' concern and clarify hospital policies and physicians' responsibilities. He also proposed that further investigation should examine how readily older persons do understand such information and determine if additional aids such as written literature, videotapes, or simplified language might help. The Journal of Critical Care in 2013 also emphasized the need for education, suggesting that in order for DNRs to be taken more seriously in the future, that professionals should be exposed to the ethical principles, specifically patient autonomy, early on in their study. Saying this, we must ask ourselves, are we as a nation more willing to accept DNR orders in the elderly than in any other age group? Would the implementation of educational policies to raise awareness and develop a universal understanding of DNR policies really work to prevent physicians' ideas and beliefs from affecting their decision making regarding DNRs in their practice? The debate goes on.